Hello everyone in CardioMinds channel, and you are still in the topic of the guidelines of cardiovascular disease prevention, and today we are speaking about the clinical conditions associated with cardiovascular risk. We have spoken before about the conventional risk factors that are strongly correlated with cardiovascular disease, and then we discussed the risk modifiers which may reclassify the risk by increasing or decreasing. And today we are speaking about the clinical conditions or the comorbidities that may be present in the past history of the patient, and they may increase the risk of cardiovascular disease, so this is a separate entity. The presence of these comorbidities may increase the likelihood of cardiovascular disease, and when they are present in patients with established cardiovascular disease, they worsen the clinical prognosis. And in this section, we are going to review some of these conditions which are not often included in the traditional risk scores, but sometimes they are integrated in some national risk scores, and so it is essential to ask about them. And of course, the logical question, why are they important to ask the patients about? Many of these clinical conditions share common risk factors with the atherosclerotic cardiovascular disease. That's why treating these risk factors and controlling them leads to a synergistic reduction in the burden of the cardiovascular disease and also in the burden of these comorbidities. Our agenda today is the chronic kidney disease, atrial fibrillation, heart failure, cancer, COPD, inflammatory diseases and infections, migraine, sleep disorders, mental disorders, non-alcoholic fatty liver disease, and the sex-specific conditions. Let's start with the chronic kidney disease, which significantly affects the risk stratification. The definition of chronic kidney disease is any abnormalities in the kidney structure or in the function which is present for more than 3 months in order to define it as being chronic rather than acute. The criteria and markers of kidney damage include the albuminuria, which is albumin-creatinine ratio more than 30 mg per gram in spot urine specimen. We don't need to do 24-hour urinary collection, or GFR less than 60 milliliter per minute. We all know the Cockcroft formula, which we famously use to calculate the GFR, but in these guidelines they emphasize the CKD-EPI equation, standing for chronic kidney disease epidemiology collaboration, which depend on the race, age, sex, and serum creatinine in order to estimate the glomerular filtration rate. Chronic kidney disease is considered the third fastest growing cause of death globally, and its prevalence is about 10 to 12%, and so it is associated with very high cardiovascular risk. Also, the cardiovascular disease is considered the leading cause of morbidity and mortality in patients with CKD, and even after adjustment of the non-conventional risk factor, the risk of mortality progressively increases with the worsening of kidney function, and there is a linear relationship between the drop in GFR and the probability of developing coronary artery disease. And if we ask ourselves, why the chronic kidney disease increase the risk of atherosclerotic cardiovascular disease? First of all, there is high prevalence of conventional risk factors like hypertension and diabetes in patients with CKD. So of course, these risk factors would increase the risk of developing cardiovascular disease. And also there is exposure to non-traditional risk factors in uremic patient like inflammation, oxidative stress, and some promoters of vascular calcification. All these pathological factors contribute to atherosclerosis and so to development of cardiovascular disease in CKD patients. That's why in the guidelines this year there is class 1 recommendation to screen all CKD patients, either diabetic or non-diabetic, for atherosclerotic cardiovascular disease and also for the progression of kidney disease by monitoring the albuminuria and the GFR. Let's now move to the atrial fibrillation. This diagram summarizes what we are trying to speak about in the atrial fibrillation as being a comorbidity. There are two types of risk factors for AF, including modifiable risk factors like hypertension, obesity, diabetes, sedentary life, and none or partially modifiable factors like aging and genetics. Lifestyle modification is very important, plus the risk factor control to reduce the burden of atrial fibrillation. Also, it is reflected on reduction of mortality and morbidity, and also the treatment of the underlying cardiovascular conditions. So risk factor here is very important in the reduction of burden of atrial fibrillation. We have two types of process in the left atrial remodeling: reversible process like electrical remodeling, biochemical or inflammation in the atrial structure, or non-reversible process like atrial fibrosis, atrial scarring, or atrial dilatation. The sequence of atrial fibrillation development range from paroxysmal atrial fibrillation to persistent and finally to permanent atrial fibrillation. The outcomes of atrial fibrillation are too wide, ranging from heart failure, affecting the symptoms and quality of life, up to stroke and up to mortality. And so we need to focus in the treatment management on the stroke prevention, cardioversion, rate control, when to proceed for catheter ablation, the role of antiarrhythmic therapy, and also we emphasize again the importance of lifestyle modification, risk factor control, and treatment of underlying cardiovascular conditions. Let's move to the heart failure. Many of us would consider heart failure as part of the spectrum of cardiovascular disease, not a separate entity, and this is partially right. Heart failure of ischemic origin is considered to be the severe clinical outcome of coronary artery disease. But if we are speaking about heart failure per se, either it is of ischemic etiology or non-ischemic etiology, the heart failure increases the risk of cardiovascular events like MI, arrhythmias, ischemic stroke, and even cardiovascular death, whatever the etiology, but the risk is higher with ischemic LV dysfunction. Also, the both of asymptomatic LV dysfunction and clinically overt heart failure increase the risk of urgent heart failure hospitalization and also the risk of cardiovascular death and all-cause death. So we can consider that the heart failure, especially the ischemic etiology, puts the patient at very high cardiovascular risk, especially for the risk of cardiovascular event, and so it justifies recommendation for secondary prevention, and several medication would be recommended to reduce the risk of morbidity and mortality, and this would be explained in detail when we start guidelines of heart failure. Now we are moving to some of the comorbidities that don't usually come into our mind when we are speaking about cardiovascular patients, and now we are speaking about the cancer. There is a fact that there is an overlap between cancer and the risk factors of cardiovascular disease due to shared biological mechanisms and also genetic predispositions in both of them. So the prevention and treatment is beneficial in reducing both cardiovascular disease as well as risk of cancer. And we can see this, for example, in the lung cancer and the colon cancer, with sometimes the unhealthy lifestyle would increase the risk of these types of cancer. The two famous lines of treatment of cancer may have deleterious effect on the heart. The chemotherapy, for example, may lead to early or late cardiovascular side effects like LV dysfunction, heart failure, hypertension, risk of coronary artery disease, and risk of arrhythmias, and therefore the effective strategy to predict and prevent cardiovascular toxicities are critically important. The radiotherapy also has its implication on the heart, and also the risk of accelerated atherosclerosis and cerebral vascular disease, and this is correlated with multiple factors like the dose of radiotherapy, the volume of the heart irradiated, concomitant administration of cardiotoxic drugs like anthracyclines, and the patient risk factors like age and the conventional risk factors of cardiovascular disease. There was a clinical study, for which the reference is mentioned below in the description of the video, that showed significantly higher risk of cardiovascular disease in survivors of childhood cancers in comparison to non-cancer adult controls, and also in the survivors of adult onset cancers with underlying risk factor. This, of course, focuses on the importance of cancer as being one of the comorbidities that may increase the risk of developing cardiovascular disease in the future. This information emphasizes the importance of screening for symptoms and signs of cardiac dysfunction in cancer patients, either before cancer treatments, periodically during cancer treatment, not just once, and also after cancer treatments. We can detect these abnormalities by imaging techniques and also by measuring circulating biomarkers of cardiac damage like troponin and PMP. Also, we can use the speckle tracking to measure the myocardial strain, which can help to predict early cardiac toxicity which may precede the decline in ejection fraction. Regarding the prevention, there were some randomized clinical trials that used RAS blockers or beta blockers in cancer patients receiving trastuzumab, which is Herceptin, or receiving anthracyclines, and these trials reported contradictory results. The benefit of these medication may be that they reduce the LV remodeling or reduce the rate of decline in ejection fraction, but its reflection on better outcomes for the patient is still speculative, and so we need much more evidence to validate the use of these medications in cancer patients. But no doubt that aerobic exercise is strongly advised in order to prevent and also to treat the chemotherapy toxicity on the heart, and the aggressive control of risk factors is recommended either in adults with cancers or in survival of childhood cancers in order to reduce the risk of cardiotoxicity and cardiovascular disease. In the guidelines this year, there is Class 1 recommendation to monitor cancer patients for cardiac dysfunction using imaging techniques and using circulating biomarkers before, periodically during and after cancer treatment. There is Class 2B to use some of the medications for cardioprotection in high-risk patients receiving anthracycline or high cumulative dose of radiotherapy to prevent LV dysfunction. Still, there is Class 1 for screening for risk factors and controlling them in order to optimize the cardiovascular disease risk profile in cancer patients. Now we are moving to the famous comorbidity chronic obstructive pulmonary disease. COPD patients have about 2 to 3-fold increased risk of cardiovascular disease in comparison to their age-matched control, even after adjustment for tobacco smoking. So not just the presence of smoking is a risk factor of cardiovascular disease in these patients. No, COPD itself may increase the risk of cardiovascular disease. Also, the patient with mild to moderate COPD are 8 to 10 times more likely to die from cardiovascular disease than respiratory failure, and the mortality increased by 28%, and the frequency of non-fatal coronary events increased by 20% for every 10% decrease in the forced expiratory volume 1, which is measured by the spirometry. Not only this, the risk of MI and ischemic stroke is increased during the first 3 months after an acute exacerbation, and COPD patients have a 2-fold higher risk of developing peripheral arterial disease, and also it is possibly associated with abdominal aortic aneurysm regardless of the smoking status. All of these facts emphasize the significant burden of COPD in relation to the cardiovascular disease. The question that usually forces itself upon our minds: why does COPD increase the risk of cardiovascular disease? First of all, both diseases share common risk factors like smoking, aging, hypertension. Also, the presence of metabolic syndrome and reduced physical activity in about 34% of COPD patients increase the risk of cardiovascular disease. The presence of hypoxia during exercise, which may be caused by lung hyperinflation, impaired vasodilator capacity, high resting heart rate, and other factors, may contribute to the development and progression of cardiovascular disease, and also the cerebral microvascular damage, which is correlated with COPD severity, increase the risk of both ischemic and hemorrhagic stroke. So we can summarize these adverse events in this quote that systemic inflammation and oxidative stress caused by COPD promote vascular remodeling, stiffness, and atherosclerosis, and also they may induce a procoagulant state. This can affect all vascular bed and so increase the risk of atherosclerotic cardiovascular disease. So COPD patients should be screened for cardiovascular disease and for the risk factor, but put in your mind that there are some challenges to diagnosis regarding the use of exercise test. Achieving adequate exercise is difficult in COPD patients, so a treadmill test would not be wise. Presence or use of vasodilators for myocardial perfusion scan may be contraindicated due to the risk of bronchospasm. Stress echo is often difficult due to poor echogenicity, so we usually resort to the CT coronaries or MRI to diagnose coronary artery disease, but of course the drawback is that they are expensive, time-consuming, and not always available for every patient. So in the guidelines this year, there is a Class 1 recommendation that all COPD patients should be screened for cardiovascular disease and also for the risk factors. Now we are moving to the inflammatory diseases and infections. The famous rheumatoid arthritis is strongly associated with cardiovascular disease as it increases the risk by 50% beyond the conventional risk factors. That's why there is a low threshold to assess the total cardiovascular risk in rheumatoid patients, as it increases the risk of premature and accelerated atherosclerosis. Inflammatory bowel disease may increase the risk of cardiovascular disease by 20%, especially in active cases. Psoriasis and ankylosing spondylitis may increase risk, but the evidence for this correlation is less strong than in inflammatory bowel diseases. But regardless of varying evidence, the risk assessment for cardiovascular disease is considered in any patient with this chronic inflammatory condition. As we know, of course, that the atherosclerosis include inflammatory components, so the presence of this disease may increase the risk of accelerated atherosclerosis. In order to start preventive interventions for these patients, putting in your mind the cumulative disease burden, the recent degree of inflammation, which are important determinants of the risk-enhancing effects. The HIV infection is very famous to be correlated with cardiovascular disease. There is a 19% increase in the risk of lower extremity disease and the coronary artery disease beyond the traditional risk factors. Also, the CD4 count may be correlated with the risk, as if it is more than 500. In this case, the risk of lower extremity event is not increased, but if the CD4 count is less than 200, the risk is about twofold higher. Also, we should not forget the protease inhibitors, which are one of the lines of treatment of HIV, which may be correlated with cardiovascular disease due to some adverse events like fat distribution, insulin resistance leading to increased blood glucose level, increased serum cholesterol, or increased serum triglycerides. All of these metabolic events may increase the risk of premature atherosclerosis and pancreatitis. There is an evidence that influenza may increase the risk of cardiovascular death during epidemics due to the cardiovascular complications of influenza like acute coronary syndrome or stroke, which are important contributors, of course, to the morbidity and mortality during influenza infection, and we have seen this also during the COVID-19 pandemic. The risk of MI or stroke may be fourfold higher after respiratory tract infection, with the highest risk in the first 3 days after diagnosis. So preventing influenza, especially by vaccination, could help to prevent influenza-triggered MI, and also we know that most cardiac patients are advised to take the influenza vaccine yearly to reduce the cardiovascular morbidity and mortality. So in the task force, there is Class 2B to assess the total cardiovascular risk in any patient with chronic inflammatory condition, but there is separate Class 2A to multiply the total cardiovascular risk by a factor of 1.5 in patients with rheumatoid arthritis. This is the only inflammatory disease to have a separate recommendation due to stronger evidence for it. Now we are moving to the migraine and its role in cardiovascular disease. There are two types of migraine, which is a migraine without aura, which is the most common type, and migraine with aura. The available data indicates that migraine is associated with twofold increase in the risk of ischemic stroke and 1.5-fold increased risk of coronary artery disease. This correlation is more evident for migraine with aura rather than without aura. And the vascular risk, of course, of migraine may be magnified by cigarette smoking and in females using combined hormonal contraceptives. The young mean age of patients with migraine may not be reflected as an absolute increase in the risk of cardiovascular disease at the individual level. But, of course, if we put in our minds the high incidence of migraines in the population, the effects of the cardiovascular disease may be significantly higher at the population level. And so in the guidelines this year, there is Class 2A that patients with migraine with aura should be considered for risk assessment for cardiovascular disease, and the Class 2B to avoid combined hormonal contraceptives in females with migraine with aura. What about the sleep disorders, including the obstructive sleep apnea? If I would advise any patient, I would advise him for at least 7 hours sleeping to be optimal for his cardiovascular health. We have multiple sleep disorders, including insomnia, parasomnia, but the most famous of them is the sleep-related breathing disorder, which is obstructive sleep apnea. All the sleep disorders, especially the sleep apnea, are strongly associated with mental disorder, and they share a mechanism of hyperarousal, which may be correlated with sympathetic stimulation, and so they increase the risk of cardiovascular disease. Obstructive sleep apnea is extensively studied in multiple trials in the literature, and it is strongly associated with cardiovascular disease, including hypertension, stroke, heart failure, coronary artery disease, and atrial fibrillation. That's why the treatment of the obstructive sleep apnea is strongly important in order to reduce the burden of these diseases. The treatment lines for obstructive sleep apnea including weight loss, alcohol abstinence, sleep hygiene, stress reduction, plus the positive airway pressure are needed, of course, for adequate treatment of this disorder, which would be reflected on the prevention of cardiovascular disease. Also, there is modest positive effect of the positive airway pressure on the blood pressure level, which may help to control the blood pressure in refractory cases. There is class 1 recommendation in the task force that patients with cardiovascular disease who are obese, hypertensive, they should be regularly screened for non-restorative sleep by asking the patient, for example, how often do you have been troubled by trouble falling or staying asleep or sleeping even too much, and if there is significant sleep problems, I should refer the patient to a specialist who is mostly a psychiatrist in order to help to control these sleep disorders. Let's speak about the mental disorders and their correlation with cardiovascular disease. The famous correlation that mental disorders increase the risk of cardiovascular disease, as they are strongly associated with development and even progression of cardiovascular disease, and so it is reflected on reduced life expectancy. And the risk, of course, increase with the severity of mental disturbance like anxiety, depression, substance abuse, or personality disorders. The problem is that there is increased risk of the abuse of psychostimulants in those patients like cocaine, which may be a powerful trigger of myocardial ischemia due to coronary vasospasm. Also, these patients may not adequately use the healthcare system due to their mental condition, so usually they don't seek medical advice due to the fear of stigma of having a mental disorder. But this is not the only type of correlation between them. Sometimes cardiovascular disease may lead to mental disorder. We can say that the onset of cardiovascular disease is associated with 2 to 3-fold increased risk of mental disorder compared to a healthy person. The 12-month prevalence of mental disorders in cardiovascular patients is about 40%, which significantly worsens their prognosis to the degree that may increase the risk of committing suicide. This explains why we should pay attention to the psychological status of our cardiovascular patient, not only dealing with them as just their cardiac condition. I should pay attention to his moods, to the risk of anxiety, to the risk of substance abuse, the risk of suicide, and I should speak with him. If I say that this patient may be at risk or he has developed a mental disorder, I should refer him to a psychiatrist. So we can say that there is an interplay between both disorders, and so we should screen every cardiac patient for the risk of mental disorders about 2 to 4 times per year, and patients with mental disorders also should be screened for risk factors of cardiovascular disease. And there is class 1 recommendation that mental disorders causing significant functional impairment or decreased use of healthcare systems should be considered for assessing their cardiovascular risk. The non-alcoholic fatty liver disease is famous to see in our clinical practice, known usually by the patient that I have fats in my liver. Most of those patients are overweight or even obese, so not uncommon to see high blood pressure, high glucose, or high lipid levels, which increase the risk of developing acute MI or stroke. But the question, is that disease associated clearly with cardiovascular disease risk? So far, we don't have strong evidence that the non-alcoholic fatty liver disease increases cardiovascular risk beyond the traditional risk factors after adjusting for the established factors. So it is not clearly associated, but this doesn't prevent me to calculate the cardiovascular risk for those patients and screening them for diabetes. In order to start the preventive measures, I should advise them to recommend a healthy lifestyle and reduce alcohol intake, which would be reflected on the burden of cardiovascular and the risk of cardiovascular disease. Finally, we are speaking about the sex-specific condition. Preeclampsia is very famous in pregnant female, which is defined as pregnancy-related hypertension accompanied by proteinuria. It is associated with increased risk of cardiovascular disease, risk of developing hypertension or diabetes in the future. However, there is no clear association between preeclampsia and cardiovascular disease after adjustment of risk factor, but of course, this doesn't prevent us to screen these females later after delivery for developing hypertension or diabetes. Gestational hypertension is the elevated blood pressure during pregnancy without proteinuria and is associated with risk of later cardiovascular disease, but not with the same strength as pre-eclampsia. So the risk for sustained or future hypertension and risk of developing diabetes is still elevated in gestational hypertension. However, also there is no clear association between them after adjustment of risk factors. Gestational diabetes has a highly increased risk of developing future diabetes, with up to 50% of these females develop diabetes within 5 years after pregnancy, and twofold increases the risk of cardiovascular disease in the future. And so these females should be screened after delivery, preferably by fasting glucose or hemoglobin A1C. Occurrence of preterm or stillbirth during pregnancy may be associated with moderate increase in the risk of cardiovascular disease, but the relative risk is not very high as in other disorders. Polycystic ovary syndrome is a famous disease in many females that is associated with increased risk of cardiovascular disease and risk of developing hypertension, but there are some conflicting data on this association. But the stronger evidence for the risk of developing diabetes with a relative risk of 2 to 4, suggesting of course that these females would benefit from screening of diabetes because they have a higher risk of hormonal disorder and risk of development of diabetes mellitus. So periodic screening is essential in these females. Premature menopause may occur in about 1% of females below 40 years of age or 10% before the age of 45 years. The problem in the premature menopause that is associated with increased risk of cardiovascular disease, and there is an inverse relationship between earlier menopause and the cardiovascular risk, that with each one decrease in the age of menopause, there is 2% increased risk of cardiovascular disease, and this is explained due to the lacking benefit of estrogen after menopause. Erectile dysfunction, which will mean the failure to initiate or to maintain erection enough for the sexual intercourse, it is having a high increased risk of all-cause mortality and cardiovascular mortality. And if we ask ourselves why, first of all, erectile dysfunction and the cardiovascular disease share common conventional risk factor and a common pathophysiology. The most common cause for organic erectile dysfunction is atherosclerosis of the penile arteries. Also, some of the medications used to prevent cardiovascular disease, like MRA, beta blockers, or thiazide, may cause erectile dysfunction. Regarding the temporal correlation with cardiovascular disease, erectile dysfunction may precede coronary artery disease, stroke, or peripheral arterial disease by about 2 to 5 years. This means that the patients complaining of erectile dysfunction have a risk of developing cardiovascular disease in the future, and the burden of course that it increases the risk of total cardiovascular events, risk of MI, risk of stroke, and risk of all-cause mortality. So there are some specific recommendations for sex-specific conditions. Class 2A, that females with preeclampsia or gestational hypertension should be periodically screened for hypertension and diabetes. Class 2A, that females with polycystic ovary syndrome or gestational diabetes should be periodically for diabetes. Class 2B, that females with preterm or stillbirth should be periodically screened for hypertension or diabetes. Here the evidence is slightly weaker. And the Class 2A, that patients with erectile dysfunction should be assessed for cardiovascular disease risk. So at the end of this video, we have discussed here these comorbidities with varying evidence from very high risk to a modest increase in the risk of cardiovascular disease. So our take-home message today is that checking the past history of any patient for non-cardiovascular disease is not less important than checking his risk factors or risk modifier, because these comorbidities can put the patient at high risk and affect my choice of medication based on his comorbidities. So it is important to ask about them in my history taking. Thank you very much for watching this video, and wait in the next video to start speaking in detail about risk stratification.